Measures specific to type of shock. Cardiogenic shock. For a patient in cardiogenic shock, the overall goal is to restore heart function and the balance between O2 supply and demand in the myocardium. Cardiac catheterization is done as soon as possible after the initial insult. Specific measures to restore blood flow include angioplasty with stenting, emergency revascularization, and valve replacement. Until these interventions are done, we must support the heart to optimize SV and CO to achieve optimal perfusion. Hemodynamic management of a patient in cardiogenic shock aims to reduce the workload of the heart through drug therapy and/or mechanical interventions. Drug choice is based on the clinical goal and thorough understanding of each drug's MOA. Drugs can be used to decrease the workload of the heart by dilating coronary arteries, e.g. nitrates, reducing preload, e.g. diuretics, afterload, e.g. vasodilators, and heart rate and contractility, e.g. beta adrenergic blockers. The patient may benefit from a circulatory assist device, e.g. intra-aortic balloon pump or ventricular assist device, VAD. The goals of this intervention are to decrease SVR and left ventricular workload so that the heart can heal. A VAD may be used as a temporary measure for the patient in cardiogenic shock who is awaiting heart transplantation. Heart transplantation is an option for a small, select group of patients with cardiogenic shock. Hypovolemic shock. The underlying principles of managing patients with hypovolemic shock focus on stopping the loss of fluid and restoring the circulating volume. We often calculate the initial fluid resuscitation using a 3-to-1 rule, 3 milliliters of isotonic crystalloid for every 1 milliliter of estimated blood loss. Septic shock. Patients in septic shock need large amounts of fluid replacement. The overall goal of fluid resuscitation is to restore the intravascular volume and organ perfusion. Initial volume resuscitation is achieved by giving 30 milliliters per kilogram of an isotonic crystalloid solution. Albumin 4 to 5% may be added when patients need substantial volumes. A fluid challenge technique, e.g. a minimum of 30 milliliters per kilogram of crystalloids, may be used and repeated until hemodynamic improvement, e.g. increase in MAP and/or CVP, change in SVV is seen. One of these methods is a passive leg raise challenge along with hemodynamic measures to monitor response. A PLR challenge provides a transient increase in fluid volume of 150 to 500 milliliters by placing the patient supine and raising the legs to 45 degrees. Response is monitored within 1 to 2 minutes by measuring CO, CI, SV, SVV, or other parameters for improvement. If the response is positive, the patient is fluid responsive and should receive more fluids. To optimize and evaluate large volume fluid resuscitation, hemodynamic monitoring with various non-invasive or invasive monitors is needed. If the patient is hypotensive after initial volume resuscitation and no longer fluid responsive, vasopressors may be added. The first drug of choice is norepinephrine. Vasodilation in low CO or vasodilation alone can cause low BP despite adequate fluid resuscitation. Vasopressin may be added for those who are refractory to initial vasopressor therapy. Exogenous vasopressin can replace the stores of physiologic vasopressin that are often depleted in septic shock. Vasopressor drugs may increase BP but can decrease SV. An inotropic agent, e.g. dobutamine, may be added to offset the decrease in SV and increase tissue perfusion. IV corticosteroids may be considered for patients in septic shock, cannot maintain an adequate BP despite vasopressor therapy and fluid resuscitation. To try to meet the increasing tissue demands coupled with a low SVR, the patient initially has a normal or high CO. If the patient is unable to achieve and maintain an adequate CO and has unmet tissue O2 demands, CO may have to be increased using drug therapy, e.g. dopamine. SCVO2 or SVO2 monitoring is used to assess the balance between O2 delivery and consumption and the adequacy of the CO. If balance is maintained, the tissue demands will be met. Broad-spectrum antibiotics are an important and early part of therapy. They should be started in the first hour of sepsis or septic shock. Obtain cultures, e.g. blood, wound, urine, stool, sputum, before antibiotics are started. However, this should not delay the start of antibiotics within the first hour. Specific antibiotics may be ordered once the organism has been identified. Glucose levels should be maintained below 180 for patients in shock. Monitor glucose levels in all patients in septic shock according to agency policy. Stress ulcer prophylaxis with proton pump inhibitors, e.g. Protonix, and VTE prophylaxis, e.g. heparin, Lovenox, are recommended. Neurogenic shock. The specific treatment of neurogenic shock is based on the cause. If the cause is spinal cord injury, general measures to promote spinal stability, e.g. spinal precautions, cervical stabilization with a collar, are initially used. Once the spine is stabilized, treatment of the hypotension and bradycardia is essential to prevent further spinal cord damage. Treatment involves the use of vasopressors, e.g. phenylephrine, to maintain BP and organ perfusion. Bradycardia may be treated with atropine. Infuse fluids cautiously, as the cause of the hypotension is not related to fluid loss. The patient with a spinal cord injury is monitored for hypothermia caused by hypothalamic dysfunction. Anaphylactic shock. The first strategy in managing patients at risk for anaphylactic shock is prevention. A thorough history is key to avoiding risk factors for anaphylaxis. The clinical presentation of anaphylactic shock is dramatic, and immediate intervention is required. Epinephrine is the first drug of choice to treat anaphylactic shock. It causes peripheral vasoconstriction and bronchodilation and opposes the effects of histamine. Diphenhydramine and histamine receptor blockers, e.g. famotidine, are given as adjunctive therapies to block the ongoing release of histamine from the allergic reaction. Maintaining a patent airway is important because the patient can quickly develop airway compromise from laryngeal edema or bronchoconstriction. Nebulized bronchodilators are highly effective. Aerosolized epinephrine can treat laryngeal edema. Yep, that's how they wrote that. Endotracheal intubation may be needed to secure and maintain a patent airway. Hypotension results from leakage of fluid out of the intravascular space into the interstitial space because of increased vascular permeability and vasodilation. Aggressive fluid resuscitation, usually with crystalloids, is needed. IV corticosteroids may be helpful in anaphylactic shock if significant hypotension persists after 1 to 2 hours of aggressive therapy. Obstructive shock. The main strategy in treating obstructive shock is early recognition and treatment to relieve or manage the obstruction. Mechanical decompression for pericardial tamponade, tension pneumothorax, and hemopneumothorax may be done by needle or tube insertion. Obstructive shock from a pulmonary embolism requires immediate anticoagulation therapy or pulmonary embolectomy. Superior vena cava syndrome, a compression or obstruction of the outflow tract of the mediastinum, may be treated by radiation, debulking, or removal of the mass or cause. A decompressive laparotomy may be done for abdominal compartment syndrome for patients with high intra-abdominal pressures and hemodynamic instability. Nursing management, shock. Nursing assessment. Your role is vital in caring for patients who are at risk for developing shock or are in a state of shock. Focus your assessment on the ABCs, airway, breathing, and circulation. Next, assess for tissue perfusion. This includes evaluating vital signs, level of consciousness, peripheral pulses, capillary refill, skin, e.g. temperature, color, moisture, and urine output. As shock progresses, the patient's neurologic status declines, urine output decreases, skin becomes cooler and mottled, and peripheral pulses decrease. To understand the complexity of the patient's clinical status, integrate all the assessment data. It is essential to obtain a brief history from the patient or caregiver, including a description of the events leading to the shock state, time of onset and duration of symptoms, and health history, e.g. medications, allergies. In addition, obtain details about any care the patient received before hospitalization. Nursing diagnosis. Nursing diagnosis for the patient in shock may include impaired cardiac output, ineffective tissue perfusion, anxiety. Planning. The overall goals for a patient in shock include evidence of adequate tissue perfusion, restoration of normal or baseline BP, recovery of organ function, avoiding complications from prolonged states of hypoperfusion, and preventing healthcare-associated complications of disease management and care. Nursing implementation, health promotion. You have a vital role in the prevention of shock, beginning with the identification of patients at risk. In general, patients who are older, are immunocompromised, or have chronic illnesses are at an increased risk. Any person who has surgery or trauma is at risk for shock resulting from hemorrhage, spinal cord injury, sepsis, and other problems. Planning is essential to help prevent shock after you identify an at-risk person. For example, a person with an acute anterior wall MI is at high risk for cardiogenic shock. The main goal for this patient is to limit the infarct size. This is done by restoring coronary blood flow through percutaneous coronary intervention, thrombolytic therapy, or surgical revascularization. Rest, analgesics, and sedation can reduce the myocardial demand for O2. Modify the ICU environment to provide care at intervals that will not increase the patient's O2 demand. For example, if the patient becomes tired with bathing, perform this care at a time that does not interfere with tests or other activities. May also increase O2 demand. A person with certain severe allergies, such as to drugs, shellfish, insect bites, and latex, is at increased risk for anaphylactic shock. This risk can be decreased if the patient is carefully assessed for allergies. Careful monitoring of fluid balance can help prevent hypovolemic shock. Ongoing monitoring of intake and output and daily weights is important. Identifying trends in the patient's condition is more meaningful than any single piece of clinical information. Carefully monitor all patients for infection. Progression from an infection to sepsis and septic shock depends on the patient's defense mechanisms. Patients who are immunocompromised are at high risk for opportunistic infections. Strategies to decrease the risk for healthcare-associated infections, HAIs, include decreasing the number of invasive catheters, e.g. central lines, bladder catheters, using aseptic technique during invasive procedures, and paying strict attention to hand washing. Change equipment per agency policy. Thoroughly sanitize or discard, if disposable, equipment between patient use. Evidence-based guidelines are available to reduce the risk for HAIs, e.g. ventilator-associated pneumonia, central line infections, catheter-associated urinary tract infections. These guidelines, called care bundles, outline key interventions aimed at reducing infections. Acute care. The role in shock involves 1. Monitoring the patient's ongoing physical and emotional status. 2. Identifying trends to detect changes in the patient's condition. 3. Planning and implementing nursing interventions and therapy. 4. Evaluating the patient's response to therapy. 5. Providing emotional support to the patient caregiver. And 6. Collaborating with other members of the interprofessional team to coordinate care. Neurologic status. Assess the patient's neurologic status, including orientation and level of consciousness, using a valid tool at least every 1 to 2 hours. Patient's neurologic status is the best indicator of cerebral blood flow. Be aware of the clinical manifestations of neurologic involvement, e.g. changes in behavior, restlessness, blurred vision, confusion, paresthesias. Note any subtle changes in the patient's mental status, e.g. mild agitation, and report them to the HCP. Orient the patient to person, place, time, and events on a regular basis. Orientation to the ICU environment is especially important. Reduce noise and light levels to control sensory input. Keep a day-night cycle of activity and rest as much as possible. Sensory overload and disruption of the patient's diurnal cycle may contribute to delirium. Cardiovascular status. Most of the therapy for shock is based on information about the patient's cardiovascular status. If the patient is unstable, continuously assess heart rate and rhythm. BP, CVP, and PA pressures, including CO, SVR, SV, and SVV if available. Monitoring trends in hemodynamic parameters provides more important information than single values. Integration of hemodynamic data with physical assessment data is essential in planning strategies to manage the patient with shock. Continuously monitor the patient's ECG to detect dysrhythmias that may result from the cardiovascular and metabolic abnormalities associated with shock. Assess heart sounds for an S3 or S4 sound or new murmurs. An S3 sound usually indicates HF. Monitor the patient's skin, e.g. upper and lower extremities, for signs of adequate perfusion. Changes in temperature, pallor, flushing, cyanosis, diaphoresis, and piloerection may indicate hypoperfusion. Give the prescribed therapy to correct cardiovascular system problems. Assess the patient's response to fluid and drug administration as often as every 5 to 10 minutes. Make appropriate adjustments, e.g. drug titration, as needed. Once tissue perfusion is restored and the patient is stabilized, you can decrease the frequency of monitoring and slowly wean the patient off drugs to support BP and tissue perfusion. Respiratory status. Frequently assess the respiratory status of the patient in shock to ensure adequate oxygenation, detect complications early, and provide data about the patient's acid-base status. At first, monitor the rate, depth, and rhythm of respirations as often as every 15 to 30 minutes. Increased rate and depth provide information about the patient's attempt to correct metabolic acidosis. Assess breath sounds every 1 to 2 hours, and as needed for any changes that may indicate fluid overload or accumulation of secretions. Use pulse oximetry to continuously monitor O2 saturation. Pulse oximetry using a patient's finger may not be accurate in a shock state because of poor peripheral circulation. Instead, attach the probe to the ear, nose, or forehead. Arterial blood gases, ABGs, give definitive information on ventilation and oxygenation status and acid-base balance. Initial interpretation of ABGs is often your responsibility. A PaO2 below 60, in the absence of chronic lung disease, indicates hypoxemia and the need for higher O2 concentrations or for a different mode of O2 administration. Low PaCO2, the low pH and low bicarbonate level, may mean that the patient is trying to compensate for metabolic acidosis from increasing lactate levels. A rising PaCO2 with a persistently low pH and PaO2 indicates the need for advanced pulmonary management. Many patients in shock are intubated and on mechanical ventilation. Maintaining a patent airway and monitoring for ventilator-related complications are critical. Renal status. At first, measure urine output every 1 to 2 hours to assess the adequacy of renal perfusion. Inserting an indwelling urinary catheter helps measure during resuscitation. Urine output below 0.5 milliliter per kilogram per hour may indicate inadequate perfusion of the kidneys. Use trends in serum creatinine values to assess renal function. Serum creatinine is a better indicator of renal function than BUN levels, since BUN is affected by the patient's catabolic state. Body temperature. Monitor temperature every 4 hours if normal. In the presence of a high or subnormal temperature, obtain hourly core temperatures, e.g. urinary, esophageal, PA catheter. Use light covers and control the room temperature to keep the patient comfortably warm. If the patient's temperature rises above 101.5 Fahrenheit, 38.6 Celsius, and the patient becomes uncomfortable or shows cardiovascular compromise, treat the fever with antipyretic drugs, e.g. ibuprofen, acetaminophen, and remove some of the patient's covers. Consider a cooling device if fever persists despite treatment. GI status. Auscultate bowel sounds at least every 4 hours. Monitor for abdominal distension. If a nasogastric tube is present, measure drainage and check for occult blood. Check all stools for occult blood. Skin integrity. Hygiene is especially important for the patient in shock because impaired tissue perfusion predisposes the patient to skin breakdown and infection. Perform bathing and other nursing measures carefully because a patient in shock has problems with O2 delivery to tissues. Use clinical judgment in determining priorities of care to limit the demands for increased O2. Monitor trends in O2 consumption, e.g. SpO2, ScVO2, SvO2, during all nursing interventions to assess the patient's tolerance of activity. The increased O2 demand that occurs during bathing and repositioning of patients with limited O2 reserves makes the prevention of pressure injuries challenging. Turn the patient at least every 1 to 2 hours. Maintain a good body alignment. Use a pressure relieving or pressure reducing mattress or a specialty bed as needed. Perform passive ranges of motion 3 or 4 times a day to maintain joint mobility and help prevent breakdown. Oral care is essential because mucous membranes may become dry and fragile in the volume-depleted patient. The intubated patient usually has difficulty swallowing, resulting in pooled secretions in the mouth. Apply a water-soluble lubricant to the lips to prevent drying and cracking. Brush the patient's teeth or gums with a soft toothbrush every 12 hours. Swab the lips and oral mucosa with a moisturizing solution every 2 to 4 hours. Emotional support and comfort. Do not underestimate the effects of fear and anxiety when the patient and caregiver are faced with a critical, life-threatening situation. Fear, anxiety, and pain may worsen respiratory distress and increase the release of catecholamines. When implementing care, monitor the patient's mental state and level of pain using valid assessment tools. Give drugs to decrease anxiety and pain as needed. Continuous infusions of benzodiazepine, e.g. lorazepam, and an opiate or sedative, e.g. morphine, propofol, diprivan, are extremely helpful in decreasing anxiety and pain. Do not overlook the patient's spiritual needs. Patients may want a visit from a chaplain, priest, rabbi, or minister. One way to provide support is to offer to call a member of the clergy rather than waiting for the patient or caregiver to express a wish for spiritual counseling. Caregivers need to be kept informed of the patient's condition. Give the patient and caregiver simple explanations of all procedures before you carry them out and information about the plan of care. If they ask questions about progress and prognosis, give simple and honest answers. If possible, same nurses should continually care for the patient. This decreases anxiety, limits conflicting information, and increases trust. If the prognosis becomes grave, support the patient's caregiver when making tough decisions, such as withdrawing life support. The interprofessional care team must promote realistic expectations and outcomes. Remember, compassion is as essential as scientific and technical expertise in the total care of the patient and caregiver. Ensure that the caregiver can spend time with the patient, provided the patient perceives this time as comforting. Explain in simple terms the purpose of any tubes and equipment attached to or surrounding the patient. Tell them what they may and may not touch. If possible, place the patient's hands and arms outside the sheets to encourage therapeutic touch. Encourage caregivers to perform simple comfort measures if desired. Provide privacy as much as possible while assuring the patient and caregiver that help is readily available should it be needed. Always position the call light in reach of the patient or caregiver. Ambulatory care. Rehabilitation of the patient who had a critical illness requires 1. Correction of the precipitating cause, 2. Prevention or early treatment of complications, and 3. Teaching focused on disease management or prevention of recurrence based on the initial cause of shock. Continue to monitor the patient for complications throughout the recovery period. These may include decreased range of motion, muscle weakness, decreased physical endurance, AKI, and fibrotic lung disease. Patients recovering from shock often need diverse services after discharge. These can include admission to transitional care units, e.g. for mechanical ventilation weaning, rehab centers, inpatient, outpatient, or home healthcare agencies. Start planning for a safe transition from hospital to home as soon as the patient is admitted to the hospital. Evaluation. The expected outcomes are that the patient who has shock will have adequate tissue perfusion with restoration of normal or baseline BP, normal organ function with no complications from hypoperfusion, decreased fear and anxiety, and increased physiologic comfort. Systemic inflammatory response syndrome and multiple organ dysfunction syndrome. Etiology and pathophysiology. Systemic inflammatory response syndrome, SIRS, is a systemic inflammatory response to a variety of insults, including infection, referred to as sepsis, ischemia, infarction, and injury. Generalized inflammation in organs remote from the initial insult characterizes SIRS. Many different mechanisms can trigger SIRS. These include mechanical tissue trauma, burns, crush injuries, surgical procedures, abscess formation, intra-abdominal extremities, ischemic or necrotic tissue, pancreatitis, vascular disease, MI, microbial invasion, bacteria, viruses, fungi, parasites, endotoxin release, gram-negative and gram-positive bacteria, global perfusion deficits, post-cardiac resuscitation, shock states, regional perfusion deficits, distal perfusion deficits. Multiple organ dysfunction syndrome, MODS, is the failure of two or more organ systems in an acutely ill patient such that homeostasis cannot be maintained without intervention. MODS results from SIRS. These two syndromes represent the ends of a continuum. Transition from SIRS to MODS does not occur in a clear-cut manner. Organ and metabolic dysfunction. When the inflammatory response is activated, consequences include the release of mediators, direct damage to the endothelium, and hypermetabolism. Vascular permeability increases. This allows mediators and protein to leak out of the endothelium and into the interstitial space. White blood cells begin to digest the foreign debris, and the coagulation cascade is activated. Hypotension, decreased perfusion, microemboli, and redistributed or shunted blood flow eventually compromise organ perfusion. The respiratory system is often the first system to show signs of dysfunction in SIRS and MODS. Inflammatory mediators have a direct effect on the pulmonary vasculature. The endothelial damage from the release of inflammatory mediators causes increased capillary permeability. This causes movement of fluid from the pulmonary vasculature into the pulmonary interstitial spaces. The fluid then moves to the alveoli, causing alveolar edema. Type 1 pneumocytes, alveolar cells, are destroyed. Type 2 pneumocytes are damaged and surfactant production is decreased. The alveoli collapse. This creates an increase in shunt blood flow to the lungs that does not take part in gas exchange, and worsening ventilation perfusion mismatch. The result is ARDS. Patients with ARDS need aggressive pulmonary management with mechanical ventilation. Cardiovascular changes include myocardial depression and massive vasodilation in response to increasing tissue demands. Vasodilation results in decreased SVR and BP. The baroreceptor reflex causes release of inotropic, increasing force of contraction, and chronotropic, increasing heart rate, factors that enhance CO. To compensate for hypotension, CO increases by an increase in heart rate and SV. Increases in capillary permeability cause a shift of albumin and fluid out of the vascular space. This further reduces venous return and thus preload. The patient becomes warm and tachycardic with a high CO and a low SVR. Other signs include decreased capillary refill, skin mottling, increased CVP and POP, and dysrhythmias. SCVO2 or SVO2 may be abnormally high because the patient is perfusing areas not consuming much O2, e.g. skin, non-working muscle. Other areas may have blood shunted away from them. Eventually, either perfusion of vital organs becomes insufficient or the cells are unable to use O2 and their function is further compromised. Neurologic dysfunction in SIRS and MODS often presents as mental status changes. These acute changes can be an early sign of SIRS or MODS. The patient may be confused and agitated, combative, disoriented, lethargic, or comatose. These changes are due to hypoxemia, the effects of inflammatory mediators, and impaired perfusion. AKI is common in SIRS and MODS. Hypoperfusion and the effects of the mediators can cause AKI. Decreased perfusion to the kidneys activates the SNS and the ROS. Stimulation of the ROS system causes systemic vasoconstriction and aldosterone-mediated sodium and water reabsorption. Another risk factor for the development of AKI is the use of nephrotoxic drugs. Many antibiotics used to treat gram-negative bacteria, e.g. aminoglycosides, can be nephrotoxic. Careful monitoring of drug levels is essential to avoid the nephrotoxic effects. The GI tract plays a key role in the development of MODS. GI motility is often decreased in critical illness, causing abdominal distension and paralytic ileus. In the early stages of SIRS and MODS, blood is shunted away from the GI mucosa, making it highly vulnerable to ischemic injury. Decreased perfusion leads to a breakdown of this normally protective mucosal barrier. This increases the risk for ulceration, GI bleeding, and bacterial movement from the GI tract into circulation. Metabolic changes are pronounced in SIRS and MODS. Both syndromes trigger a hypermetabolic response. Glycogen stores are rapidly converted to glucose, glycogenolysis. Once glycogen is depleted, amino acids are converted to glucose, gluconeogenesis, reducing protein stores. Fatty acids are mobilized for fuel. Catecholamines and glucocorticoids are released and cause hyperglycemia and insulin resistance. The net result is a catabolic state with a loss of lean body mass, muscle. The hypermetabolism associated with SIRS and MODS may last for several days and cause liver dysfunction. Liver dysfunction in MODS may begin long before clinical evidence of it is present. Protein synthesis is impaired. The liver cannot make albumin, one of the key proteins in maintaining plasma oncotic pressure. This changes plasma oncotic pressure, causing fluid and protein to leak from the vascular spaces to the interstitial space. At this point, giving albumin does not normalize oncotic pressure in these patients. As the state of hypermetabolism persists, the patient cannot convert lactate to glucose, and lactate accumulates, lactic acidosis. Despite increases in glycogenolysis and gluconeogenesis, eventually the liver cannot maintain an adequate glucose level and the patient becomes hypoglycemic. Hypoglycemia can also develop due to acute adrenal insufficiency. DIC may result from dysfunction of the coagulation system. DIC causes microvascular clotting and bleeding at the same time because of the depletion of clotting factors and excessive fibrinolysis. Electrolyte imbalances are common and result from the hormonal and metabolic changes and fluid shifts. These changes worsen mental status changes, neuromuscular dysfunction, and dysrhythmias. The release of ADH and aldosterone results in sodium and water retention. Aldosterone increases urinary potassium loss, and catecholamines cause potassium to move into the cell, resulting in hypokalemia. Hypokalemia is associated with dysrhythmias and muscle weakness. Metabolic acidosis results from impaired tissue perfusion. Hypoxia and the shift to anaerobic metabolism. This increases lactate levels. Progressive renal dysfunction also contributes to metabolic acidosis. Hypocalcemia, hypomagnesemia, and hypophosphatemia are common. Nursing and interprofessional management, SIRS and MODS. Prognosis for the patient with MODS is poor, with mortality rates of 40 to 60%. Mortality increases as more organ systems fail. The most common cause of death continues to be sepsis. Survival improves with early goal-directed therapy. So the most important goal is to prevent SIRS from progressing to MODS. A critical part of your role is vigilant assessment and ongoing monitoring to detect early signs of deterioration or organ dysfunction. Interprofessional care for patients with SIRS and MODS focuses on 1. Prevention and treatment of infection. 2. Maintaining tissue oxygenation. 3. Nutritional and metabolic support. And 4. Appropriate support of individual failing organs. Prevention and treatment of infection. Aggressive infection control strategies are essential to decrease the risk for HAIs, Early aggressive surgery is recommended to remove necrotic tissue that can provide a culture medium for microorganisms. Aggressive pulmonary management, including early mobilization, can reduce the risk for infection. Strict asepsis can decrease infections related to intra-arterial lines, endotracheal tubes, indwelling urinary catheters, IV lines, and other invasive devices or procedures. Daily assessment of the ongoing need for invasive lines and other devices is an important strategy to prevent or limit HAIs. Despite aggressive strategies, infection may develop. Once an infection is suspected, begin interventions to treat the cause. Send appropriate cultures and start broad-spectrum antibiotic therapy as ordered. Adjust therapy based on the culture results if needed. Maintenance of tissue oxygenation. Hypoxemia often occurs because patients have greater O2 needs and decreased O2 supply to the tissues. Interventions that decrease O2 demand and increase O2 delivery are essential. Sedation, mechanical ventilation, analgesia, and rest may decrease O2 demand and should be considered. Treating fever, chills, and pain decrease O2 demand. O2 delivery may be optimized by using individualized tidal volumes with positive end expiratory pressure, increasing preload, e.g. fluids, or myocardial contractility to enhance CO or reduce afterload to increase CO. Nutritional and metabolic needs. Hypermetabolism can result in profound weight loss, cachexia, and further organ failure. Protein-calorie malnutrition is a key sign of hypermetabolism. Total energy expenditure is often increased 1.5 to 2.0 times the normal metabolic rate. Because of their short half-life, monitor plasma transferrin and prealbumin levels to assess hepatic protein synthesis. The goal of nutritional support is to preserve organ function. Providing early and optimal nutrition decreases morbidity and mortality rates. EN is preferred. If it cannot be used, PN should be considered. Provide glycemic controls, the goal of less than 180 milligrams per deciliter with insulin infusions in these patients. Support of failing organs. Support of any failing organ is a goal of therapy. For example, patient with ARDS requires aggressive O2 therapy and mechanical ventilation. DIC should be treated appropriately, e.g. blood products. Renal failure may require dialysis. Continuous renal replacement therapy is better tolerated than hemodialysis, especially in a patient with hemodynamic instability. A final consideration may be that further interventions are futile. It is important to maintain communication between the healthcare team and the patient's caregiver about realistic goals and likely outcomes for the patient with MODS. Withdrawal of life support and starting end-of-life care may be the best options for the patient.